Direct laminate veneers are an aesthetic, minimally invasive alternative to indirect techniques. More and more patients are seeking this technique as they become aware of the benefits of reversible dentistry.
Our patient is an attractive lady whose lingually inclined upper incisors and canines with their stained labial restorations do little to improve her appearance. Microabrasion is well suited for preparing teeth for direct laminates. Surface stains, pellicle, plaque and non-metallic restorations are rapidly and painlessly removed, creating a superior tooth surface to place adhesive dentistry. The particle beam, like an air rotor, is potentially dangerous and must always be directed away from soft tissues. Crevicular exudate occurs even in healthy gingiva and must be stopped to prevent marginal staining. Used with care and in minute amounts with an antidote of sodium bicarbonate solution on hand and protective glasses. Trichloroacetic acid is a powerful astringent. The white eschar that forms on gingival tissues is painless and will disappear without scarring in about 2 hours. A 37% phosphoric acid cream is used to etch the teeth. The cream is brushed over the surface for less than 10 seconds and flushed carefully to avoid the bitter taste. The teeth are then dried with oil-free air. A light-activated, resin-modified glass ionomer bonding agent is prepared by placing a scoop of powder and a drop of liquid in a dappens dish and mixed with a micro brush to a creamy consistence. The resin ionomer bond is brushed over the tooth surface and cured prior to the placement of the composite resin laminates. This creates a high-quality seal and acts as a stress breaker between the brittle enamel and composite surfaces that both have different coefficients of thermal expansion and a different modulus of elasticity. This is an opportunity to move the camera away from the clinician's eye view to demonstrate laminate placement. Microfill composites are best suited for direct laminates as they maintain their luster for many years and reflect light by Rayleigh scattering, similarly to tooth enamel. The resin-modified glass ionomer bond and composite are simultaneously photo-initiated, co-cured, for about 5 seconds. The adhesion of composite to enamel with a resin-based bonding system creates stress at the restorative interface. This is confirmed by the birefringence present when viewed under polarized light. When a composite resin and resin-modified glass ionomer bond are co-cured to the enamel surface, the slower setting glass ionomer sets after the polymerization shrinkage of the composite and no stress occurs. If resin-modified glass ionomer bond is used between layers of resin during laminate development, lines of the low-gloss glass ionomer will appear across the laminate surface. It is therefore necessary to use a standard bonding resin when layering. The resin bond is brushed over the composite and resin ionomer bond on the tooth surface. In general, laminates are made at the same time in order to maximise uniformity in colour, contour and the surface texture. The body shade is applied over the cervical increment using a warts carver by puddling it into the tooth surface. Controlling the composite at the proximal and incisal margins is carried out with either blade of the carver. Remember, when forming the incisal edge, to roll the unset resin over the lingual surface to assure that there is no deficiencies in this area. Some practitioners find it useful to turn the intensity of the overhead light down during this part of laminate construction to avoid premature polymerization of the composite. Once the body increment has been placed, small vertical grooves are pressed into the surface with the edge of the carver blade. White tints are used to characterize the small vertical lines often seen on enamel surfaces. The white tint is spread sparingly over the laminate and cured for 5 seconds. A red tint may be used to increase the warmth of the laminates. Like trace elements in soil productivity, correct use with small amounts at the proximal margins will warm and enhance the laminate. Overuse will ruin it. A further layer of resin bond is brushed over the laminate surfaces. An enamel shade is placed at the incisal third of the laminate to improve brightness. The same technique is used in succession for each laminate. Fixed cheek retractors facilitate laminate placement beyond the canines. After placement, each increment is spot cured for 5 seconds. paper point is placed between the central incisors and a mylar strip wedged into the proximal space. A further batch of resin ionomer bond is mixed. Resin ionomer bond is puddled into the proximal margin, and an increment of incisal shade microfill resin is placed into it and rounded over the incisal edge. The mylar strip is folded over the labial and lingual surfaces, making sure that the mylar strip is in the correct position and cured for 5 seconds. The lingual aspect is also cured for 5 seconds. The mylar strip is located against the adjacent proximal margin and wedged with the paper point, and incisal shade resin is similarly placed. The facial surfaces is spot cured for 5 seconds, as is the lingual. The midline is an important aesthetic parameter that requires correct positioning for a successful aesthetic outcome. Each proximal margin is similarly created. It is useful to leave the paper points in place until the proximal margins have been completed to prevent any bleeding that may occur when points are removed. Now that resin placement is complete, each laminate is light cured for a further 20 seconds on the facial and lingual surfaces. The laminates are now ready for contouring. Initial reduction is carried out with an extra coarse Moore's emery disc. The next parameter to be addressed is the golden proportion. This universal ratio of approximately 0.6 to 1 should be applied to the length-width ratio of single laminates and to the width relationships of laminates to each other. The gross reduction of the labial surfaces gives clinicians some scope to adjust golden proportion at this stage. Gross reduction on the lingual is done with a high-speed round diamond burr. Further facial reduction is done with a high-speed tapered diamond burr. The smile line is defined as the incisal contour of the upper teeth, that is ideally parallel to that of a smiling lower lip. While some patients have challenging smiles, it is usually one of the easiest aesthetic parameters to achieve. It may be helpful to stand in front of your patient and seek the help of your assistant from the opposite side of the face to achieve the best results. In difficult cases, use a hypothetical line parallel to the patient's eyes for guidance. Cervical margins are contoured with fine, high-speed diamond points or 12-fluted tungsten carbide burrs. While it is easier to see without water spray, and also post-curing is enhanced, some patients may require local anesthetic during this procedure. The use of paper points eliminates proximal overhangs and minimal cervical contouring is required. Reducing the cervical embrasures rejuvenates the smile, and minimal opening of cervical embrasures is recommended. Cervical contours are created with slow-speed tapered diamond burrs. Incisal embrasures should be parallel and mirror images of the opposite side of the arch. Note the finger positions used to protect the patient's tissues from disc trauma. The lateral emerging profiles should be parallel and taken from the first visible tooth beyond the laminates. Anteriorly, the emergence profile of the laminate should be parallel to the contour of the patient's face while smiling. To create a natural-looking laminate, the peripheral contours must be well defined on the mesial incisal aspects and softly blend into the arch on the distal. This is achieved by long gentle arcs on the distal and short well-defined arcs on the mesial and incisal margins. A 12-fluted tungsten carbide burr can be used to fine-tune the lateral contours. The laminates often require separation with a metal discs. An abrasive metal strip is used to remove any resin tags. And after checking with dental floss to confirm that there are no proximal irregularities, a flexible abrasive strip is employed to finish the interproximal spaces. Final contouring of the proximal, incisal and cervical margins are carried out with a small interproximal disc. The surface texture of the laminates is created by making short, multiple strokes with a high-speed, pear-shaped stone. Finishing is commenced with a small, coarse silicone rubber wheel, as discs will remove the surface texturing. Finishing continues using finer silicone rubber wheels held vertical to the laminates to avoid putting horizontal divots into the surface. As the wheels become finer, a high luster starts to appear on the microfill resin surface. The final polishing is done with a small superfine disc. Each laminate is now photo cured for a further 20 seconds to maximise the hardness of the outer surface. An incisal view confirms the regularity of the laminate contours. From the labial aspect, the uniformity of the laminates is evident. There is minimal trauma to the gingival tissues, and after 2 hours, the white eschar from the trichloroacetic acid has completely disappeared. This is the moment of truth. Most patients are elated with the end result, but expect an occasional unusual reaction because of the significant change in body image that has occurred. This is how the teeth looked 2 hours previously. Patients are scheduled for an appointment in 1 week for a further polishing after post-polymerization curing has occurred. After a week, and the gingival tissues have settled down, it is evident the improvement that has been achieved in this lady's smile.
This is a predictable and fun way to practice dentistry. It gives good fiscal returns, and you'll find that grateful patients will tell their friends. If you'd like some more information about this technique or other videos in the series, I can be contacted on the following email or fax numbers, or check out the website. And thanks for watching this video.